Greetings and welcome to AWHONN Insights, the home for candid nursing conversations. Today, we welcome Jonathan Epstein, who leads the healthcare product management team at the American Red Cross, and Julie Bacon, a subject matter expert for newborn resuscitation and pediatrics for the American Red Cross with more than 25 years' experience in emergency transport medicine. In this episode, we explore the newly launched Neonatal Advanced Life Support NALS program, created by the American Red Cross in collaboration with AWHONN. This course fills a critical gap in neonatal emergency response education. You're going to learn how NALS differs from existing programs, what it offers healthcare professionals, and how you can bring it to your team. I'm your host, Bria Anopise, and I'm joined by Sarah Koppel, AWHONN Director of Perinatal Programs. Sarah served as the AWHONN subject matter expert for the NALS program. Sarah, let's get into the details of why we need skilled providers in neonatal resuscitation.
Thank you so much, Bria. We're going to start with the basics. So, what is the Neonatal Advanced Life Support or NALS program, and what inspired its development? Jonathan, do you want to give a background overview?
Yeah, great, Sarah. And first, the collaboration of the American Red Cross and AWHONN and bringing this product, this new educational choice to market is so invaluable. Really bringing our resuscitation suite and our kind of educational methodology and innovation with AWHONN's expertise. With newborn care, it was really kind of a marriage made in heaven in some respects. We really put together a program that I think everyone's going to be really, really proud of. The NALS program really was, this creation of really attacking a couple problems that were in the market today. First, the big one, maternity care deserts. 35% of this nation's counties don't have access to appropriate maternity care. We're seeing greater number of out-of-hospital births, births in emergency departments, home birth, birthing centers, but making sure that we have that training available for the folks that are attending those births was so critical, that the Red Cross, along with AWHONN, felt it was important to bring this NALS program to life. I think the other piece of what we wanted to do between Red Cross and AWHONN is make sure, one, that we had an evidence-based, science-backed program. So this program, and the other programs that are in the market today, when we think about the science in the background, we want to make sure there's no bedside conflict. We want to make sure that if you're trained in NALS or another program, what you're doing at the bedside, what you're doing at that birth of a newborn is the same treatment recommendations. So our science, our guidelines come from ILCOR, the International Liaison Committee on Resuscitation, which is where the American Heart Association, American Academy of Pediatrics pull their guidelines from as well. Those same treatment recommendations, we've kind of distilled them down so we match treatment for treatment. So that was kind of priority one in this development, that we have a same science program, but maybe more innovative educational approach, and then expanding the access to kind of go after those maternity care deserts and really make sure whether you're in a level 4 NICU or you're in the side of a road or in a home or in a critical access emergency department, those newborns are getting the right care and trying to improve outcomes.
Definitely. Julie, would you talk to me about the current state of neonatal resuscitation education?
Hey, Sarah, it's so nice to be here this morning. When we took a look a couple of years ago, when I was brought in and asked to come on board as a subject matter expert, I really had my knowledge base just expanded on, number one, where do the guidelines for neonatal resuscitation live? I have been credentialed in that for many years, as we mentioned before, but never really thought about where did that come from. And I think it was new knowledge for me to learn about ILCOR, to learn that there was this overriding international scientific body that gave us best practice. So when we took this and put it into programs that's existed for years, then it takes a look at, when we look at NALS, it's like, what are we looking at here? One of my real burdens and my the path that I wanted to see taken is to make the accessibility broader. We know that the program for NALS and the other resuscitation programs, they speak to the neonatal ICU, they speak to labor and delivery. But I found over time that as I dealt with our EMS providers, our community healthcare providers, our midwives, that whole area there, they were having a very difficult time, accessing the science. So while we have really good scientific guidelines on best outcomes for neonates, we need to be able to get it to the rest of the continuum. And I think that's what really made me excited about being involved in this project and seeing NALS as it's rolled out, is that it is all of the providers from the NICU to the L&D, plus some of the other providers that have been needing this information for a long time, but had a difficult time either finding classes or instructors or getting that to, as Jonathan mentioned earlier, the side of the road. So right now, that's really the exciting part, is that neonatal resuscitation information, advanced life support, is now available and accessible to all providers.
Definitely. And how do you feel like NALS is innovative?
Oh, can I keep being excited about that? Okay.
Absolutely.
So a couple of things. Here is the first thing is that I think that the material speaks to the provider. I don't know about you, Sarah, but you've taken classes where you have many, many textbooks for the class, and you line them up and they read like a textbook. And quite frankly, you never open them again and you dust them off once a month. When I went through NOWS the first time, as someone that has taken these types of classes for a long time, I was brought in by the way it's presented, the way it spoke to me on this is what's important very clearly. This is how you can make a difference in the newborn population. So I think that you can have the best science, but if no one opens the book, then you're not going to be able to have it to provide. So I think the materials are amazing, and Jonathan's going to speak to those a little later. I think the fact that we have integrated the out of hospital provider into a text is really innovative. And, when you and I were working on it, we were very excited about how does this speak to the NICU or to the L&D? How does it speak to the EMS provider or to the midwife or to the community hospital? And making the ability to have instructors more available for the out of hospital teams, I think those are probably the biggest innovations that I could think of.
I agree with that. And I think as we went through the scenarios, we ensured that we met both of those needs too, and had the in-hospital scenarios and the out-of-hospital scenarios. So that way you could really visualize yourself being in that scenario, regardless of what your role was too. So
Yeah, yeah, absolutely. I think, when we think of innovation and just from an education and learning perspective, and Red Cross, we've done this with other resuscitation programs, whether it be BLS, ALS, PALS, but really took it to a new level with NALS of that contextual learning, something that we call practice as you perform, really making sure that we're letting people train in the way they're going to work based on their scope, based on their training, based on their environment, with medical oversight. It's not a rigid program. It's allowing that flexibility to make sure we're meeting the audience where they work. We know medical error is one of the leading causes of death in hospitals. So if we let people actually use checklists, use resources, use the tools they're going to use day to day in the classroom, as well as they have to train once, not train twice. So really, really important innovatively from the educational approach. Certainly, Sarah, you talked about the out of hospital versus the in hospital. Whether you're an emergency physician, emergency nurse, whether you're in the L&D or NICU, or whether you're a midwife or a paramedic, you're learning contextually based on those scenarios. We're speaking to that environment, which is so important. And now that we've run a series of these courses and instructor development courses throughout the country, we're really seeing it take off. And we're really seeing people really resonate to the learning itself, which I think is the most innovative piece. And yes, we have adaptive learning and a new approach to the delivery of cases in our comprehensive program. There's a lot of innovation in the way we deliver it, but it's really allowing that flexibility and speaking to the audience where they are. And it's not a textbook. It really feels something that's usable, as Julie talks about, has been so important to the kind of the uptick of the NALS program so far.
Can I add on to that? Just he sparked a couple things for me. As number one, when Jonathan was talking about using your resources, I know as we teach, we're like, if you couldn't do algebra in the 9th grade, what makes you think you can do those calculations in your head at a bedside during a resuscitation? Use your resources. And there are great resources available in NALS, and we encourage them to use them, which is my second point, in the hands-on scenarios. If you don't connect that knowledge to your muscle memory, then we're missing here. So whether you are a physician, a nurse, a midwife, a paramedic, an EMT, when you take NALS, you will have hands-on applying the knowledge base to that scenario and using your resources in hand.
Yeah, one of the resources that I really appreciated as we were working on it was the algorithm. I know with the algorithms sometimes are very short and concise, and you have to go back to the textbook to really find the answers about how long you do different things, what each step entails. And one thing that I'm really proud of is the algorithm. It is 2 pages, but it gives the details so that way you have the majority of the information you need within the algorithm. So the majority of the time you should be able to resuscitate the baby with side 1. So you should be able to do your ventilation corrective steps, have effective ventilation. Once you are able to achieve that effective ventilation, the majority of the time, that's all that baby needs. It's only if you need to go to chest compressions and medications, would you actually need the second side. So it would be rare that you have to flip it over, but it provides you all that information that you need. So that way it is all right there and you don't have to really keep on going back and forth in between a text and the algorithm. So that is one thing that I was thought was very innovative as we were working on it. And then the other thing was the SOPA or Mr. SOPA versus RAPA, as we were working on it with the ventilation corrective steps, with the repositioning the head, assessing the airway, making sure that it's clear of secretions, increasing the pressure and the alternative airway. We really thought that RAPA described what was needed in a short, concise way. And I loved Julie's way of describing this. If you'd like to share.
Well, this was our actual conversation as we're looking at these really important steps. And the important thing is, can you remember, can you apply them in that moment that's very high stress, very adrenaline, right? And we started thinking, and my thought was, if I send my husband to the store with 6 items that he has to remember versus 4 items, what am my best bet is I'm going to get 4 items rather than 6. And it's interesting and that's what been our feedback. It's like, so what we did is we consolidated a little bit. We didn't dilute the message down of those interventions and those steps. But when you have the wrap up, we have found people said, oh, it's much easier to remember 4 steps than it is for 6.
Yeah. And what you don't know, Julie and Sarah, because we got word of this from the other day, we've already had some large agencies change their protocols and have put RAPA into their protocols because they're finding it easier in the classroom. So one of the large EMS and hospital systems in Nevada has already made a switch to NALS, and they're actually making a switch and putting RAPAs already in their protocol to kind of focus on those corrective measures. It's resonating really because it's a simple message.
Definitely. And to us, it made sense because it was, you do M and R together, and then you try your ventilations, and then you do S and O together, and then you do your ventilations. So, and then you just do P and just do A. So it was like hard for people to really remember, oh, do I ventilate in between each of the steps? Oh, it's just after the first 2, after the first 2, after 1, after 1. So really just making it, you do a letter, you attempt ventilation, just really helped simplify it. I'm very excited for that, Jonathan. That's exciting to hear that news.
Yeah. And then I think some other things, just for differentiators, talking about obviously the science and education it is top notch. But kind of some of the other differences, just from a Red Cross perspective, and our collaboration with AWHONN was really, and Julie talked about it, and Sarah, I think you did as well, accessibility and choice. We're trying to make this course accessible to all audiences. So when we look at materials, Red Cross, all of our materials digitally are free. We do not charge for our instructor manuals, the use of our videos, student ebooks at no cost. So everything we want to make sure is available. If someone needs that access, dollars aren't going to be the impediment to getting training out to the midwives or nurses in a critical access hospital, or even in the NICU when there's a lot of financial pressures across healthcare today. We want to make sure, again, choice and accessibility. So things like the free ebook, instructor manual PDFs, all the video, all those resources are available digitally free. And then even if someone wants the print resources, and we encourage those print code and reference cards and our warmer cards and our badge buddies and all those elements that we have them for print, they're really inexpensive, really easy and affordable to bring into a system to make sure people have the tools they need. So we're not letting price be a barrier. We're also not letting price be a barrier for instructors to come over and learn how to teach the NALS program in health systems and other locations as well. We're trying to make this as simple and as low cost of transition as possible, again, to bring more access. We're trying to take care of these 35% of counties in the United States that increase of out-of-hospital births. We've got to get this training out to more people.
One thing you breezed right over, but is the instructor manual. And for those instructors for neonatal resuscitation, you will love this instructor manual. You can, as Jonathan mentioned, have it for free as a PDF, or you can purchase it on the website, very reasonably priced, but it is very comprehensive, gives sample agendas, layouts, all the case scenarios, many for both types of the programs, and we'll get into the differences in that here shortly, but it's very comprehensive and gives you all the supplies and references that you would need to really have a successful class. So that is a great asset for this course. And then speaking of, could you walk us through the structure of the course? What can learners expect in terms of content, delivery format with this certification?
Sure, I'll start and certainly jump in. Julie and Sarah is the primary builders of this program, but the NALS program, and there's really two of them. There's a foundational level course, and then a comprehensive level course. They're both blended learning options, so they both entail an online learning environment or an online session that's someone will complete, followed by an in-person skills assessment where we'll verify competency in those skills through a team-based approach. So taking a step back, let's kind of break those up. So NALS Foundations course is really meant for those clinicians or those providers, broadly defined, that are going to have a response team or a more advanced team respond to them in the matter of a few moments. So it's really getting through those key concepts of the immediate birth, through that positive pressure ventilation, getting those ventilations started, LMA, OG2, but really not going further than that. It's really getting through, as Sarah, you talked about, the first page of the code card, getting that ventilations going and that real focus on good positive pressure ventilation and RAPA. That course is really, from a learning perspective, foundational. It's a foundations course. So it's not adaptive from a learning perspective. We're assuming that we're going to kind of share all the learning of that foundational content to every learner in a really beautiful, engaging online environment, and then bring them in an online post-summative exam, but then bring into the classroom environment. We'll spend about 2.5 hours or so going through the primary skill stations of ventilation, ventilation-based components, and then that team response scenario and testing. The comprehensive course is really geared for those, again, clinicians, providers that are the resuscitative team or do not have another team responding to them. That's also an online environment and that blended learning, but that becomes an adaptive program. So those learners, those course participants that are experienced, have been through this content and material ahead of time, or have taken a resuscitation course many, many times over the course of the last several years. They may go through that pre-assessment and knock off or kind of get to skip through some of the foundation content. Once completing the foundational material, which everyone has access to, whether in hospital or out of hospital, you'll choose which track you want to take. When you finish that, you'll go into an in-person environment, again, for about a 3.5 hour session, adding all the more advanced skills, UVC, IO, epinephrine administration, certainly coordination of chest compression with PPV. But it's, again, those team-based scenarios that actually practicing and then testing as a team going through those predefined scenarios. So again, we've got scenarios for in and out of hospital, geared for different settings within the hospital environment. But the courses themselves really run what you'd expect other courses to be like, but it's very, very engaging. So blended learning, online session followed by those in-person kind of psychomotor skill verification and testing. So I don't know if Julie, you want to add to that, certainly.
I think as you were talking about the team-based, a lot of conversation went into what does a team look like, and recognizing that throughout the continuum, a team in the NICU or a team at a high level L&D is going to look very different than a team at a birthing center or maybe EMS, on scene, and recognizing and really emphasizing the important team components and practicing those, but having still that conversation of understanding you may not have 5 people or 6 people on your team. You may have 2 or 3, and still recognizing those foundational components and how do we fit those into the resuscitation for best outcomes.
Yeah. And I think the other piece of the course, and this comes back to a little bit of the innovation, when we get into that classroom environment, when we talked about that practice as you perform earlier, really understanding what those limitations are. I think what we didn't talk about is within the participant's manual, the instructor's manual, the online learning, there are specific call outs when you don't have, let's say, a radiant warmer or an oxygen blender, because I'm in a low resource area. I'm in an emergency department in a small rural hospital, or a critical access environment, or it could be a home birth or a birthing center. I don't have those resources. We actually talk about throughout the course and allow you to bring those elements into the in-person sessions of what equipment do you have? What do you have access to? And really, while we're teaching you the skills, you're going to learn all the skills that's required. But when you get into those team environments, you're really going to say, I don't have a radiant warmer in the back of an ambulance. What am I going to do? Thermal heat pad or mattresses, things like that are built into the course. We're actually they're not tricks of the trade, but they're actually just those alternatives. We're teaching everything, but we're actually saying, how would you accomplish the same goal of maintaining body temperature, as an example? How would you do it in these other environments? I just want to kind of add that in. We let you incorporate that both in the in-person, but also teach it in the book and in the online environments as well.
Well, and I think that raises a really great point, because that isn't just like EMS and paramedics and different things like that. That actually applies to the hospital too. You have a patient who pulls up and they've maybe waited at home too long, and they don't have time to get up to the OB floor and give birth, say, in their car, in the waiting room, on their way while waiting for the elevator up to the unit. And you don't have that compressed air source there or oxygen source. So how could you have this resuscitation outside of the delivery room? And so it gives you really good tips for that too. So, you can use your self-inflating bag, and it doesn't have to be attached to anything. So throughout the course, those tips can really be applied even to the in-hospital crowd, as well as the out of hospital. Or maybe you have this baby that you're taking down to radiology or ultrasound for a test, and it stops breathing. So it really can be applied for everyone. My next question has to do with challenges or surprises. So, were there any challenges or surprises during the development process of the NALS course, and what lessons did you learn along the way?
Well, I know that as we delved into it and really got into science and best outcomes, having to do with delayed cord clamping. And my background is I have NICU background. I've worked in the hospital, but I also run a transport team. And we go into rural areas. So I have 1 foot in the hospital, 1 foot in EMS, maybe a foot and a half in EMS. So as we talked about delayed cord clamping, I came from this culture that while I know a lot about neonates, it was like I was always there for the preemie, for the child that was anticipated being sick, right? For the emergency. And it was always, quick, get that preemie, cut the cord, get them over, we'll start working on them. And as we started getting into the science of delayed cord clamping, like even, that 30 to 60 seconds, and being aware that I can do my first steps in resuscitation. And that's what the code card says, on mom's chest, on the parent's chest, allowing for that continued perfusion of the baby. And Sarah was just amazing at this and sending me articles and going, look what happens. Look at the amazing results, even with the sickest, smallest, because I'd be like, Sarah, but not for 25 weekers, right? But not for and she's like, no, look at this. And knowing that something so relatively simple, taking a very short time, not delaying the advanced life support, but building it into it could change outcomes. That was mind-boggling for me. And I love bringing that out, particularly to our providers that hasn't been the culture in the past.
Yeah, that's great, Julie. And I think for me, obviously the science and our focus, make sure we have the evidence right, and then we don't have that bedside conflict, which I think was certainly a challenge in building, making sure that we are aligned so that folks who train in different organizations can actually work together when they come together. Certainly in the out of hospital environment, but even in the in hospital. That Red Cross, we train most of the U.S. military. So when they're leaving the military roles, going to civilian hospitals, we want to make sure they come in, they're ready to work. So I think that alignment of the best science, the same guidelines, is certainly a challenge that we certainly overcame, and I think we did it really, really well. But kind of the elephant in the room challenge was really we brought a new choice into the market with NALS, AWHONN, and the American Red Cross together, when there's been really one program for 30 plus years. And we wanted to make sure that we're hitting all those key elements, that it's, again, high quality education, it's innovative, that it is hands-on and psychomotor, that we're letting people practice skills and test them appropriately. And so I think those challenges of kind of getting this course out into a marketplace that, there's been one thing out there forever, and now we have kind of a new program, and it's certainly one worth looking at and incorporating into people's choices of educational provider. But also I think that the concept now is that this is not, while I am an EMS provider, but I'm also a healthcare educator, this course is not made for EMS. This course is made for all settings. It is made for in the labor and delivery suite, in the level 3 and 4 NICUs as well. And I think that's been a challenge that a lot of people think, well, there's one program for in-hospital, one program for out-of-hospital. That's really not the case. And I think we're kind of, because we are looking at that maternity care desert issue, the challenge of that, we didn't build this just for an EMS environment. We really built this for everybody, to give everybody this access to this great education, innovative thinking, same science. And that was certainly a challenge. And we're still trying to overcome that today, the objections of, well, that's just for EMS, but it's not. It is really for the hospital. And its primary base is a hospital-based program that has called out for all the other locations, including the midwives, birthing centers, home births. And we really, Julie says it a lot of times to me, the delivery room is where the baby's born. It may not be in a hospital.
And, I think that that's so important in the fact that we are empowering populations or target audiences that in the past haven't felt like they had the information to be able to make the difference, right? I remember years ago, I was teaching next to a class of paramedics, and they were going to talk about delivery of a baby. So of course my ears perked up, and he says, I only have one thing to say, just go fast. And I went, how sad is that you have all these experienced providers, because they haven't had the information and the good science. So here we have this amazing science and skills and interventions that we have in hospital. We now want to bring the other communities into the fold and empower them to make a difference in a newborn in the same way we are doing it in a level 3 NICU or whatever, So you're right. It's not separating out. It's really bringing in and starting that high level of care wherever that delivery room is at.
Right. And we're seeing the effects of that already. Again, I talked about where RAP has been incorporated into some large system protocols. They also all about TPs resuscitated T-pieces for everybody. I won't do the brand names, but they're buying other equipment, they're updating their protocols. Neonatal education is not required in a lot of locations. They use PALS as a surrogate. And it's scary from a product person, to say, oh, we built something that's not actually required education. But there's such a lack of understanding in that need that we're elevating EMS systems. We're elevating, non-traditional locations of, whether it be like critical access, some rural EDs, whatever it may be. We're trying to elevate everyone with that information and access to that information for the first time. And it's affecting change already. We're seeing protocols and equipment changes and a real focus on this is important. And the lives of these newborns, and again, these deserts, about 150,000 to 200,000 births a year are affected by this. We want to have the right people there ready to go.
Absolutely. I think another challenge as we were developing the program was just trying to ensure that all the content was really up to date with the latest science, with an ever-evolving science. We know previously or historically, when creating content or writing a paper or doing whatever in school, like you had to make sure your sources were within the last 5 to 10 years or that type of thing. But with this, it's that ever evolving science. And so really keeping our keeping a pulse on where is resuscitation science. And we were just looking for all the ILCOR updates, all the science updates, and just making sure that we had the very most up-to-date science as we were creating the program. It was a challenge, but it was fun seeing what new science was coming out, especially with cord milking, something that we were told, never to do. And with the science that came out about that, with making sure babies were greater than 28 weeks, but if time was of the essence, with using it compared to delayed cord clamping. So there's a lot more that goes into that. So definitely check out the curriculum to read about when that would be appropriate. But just that ever-evolving science was fun to see as it was coming up, and then just making sure that we had the latest and greatest up-to-date science was one of the things that I would mention too. And then how can hospitals, educators, or individual providers really get involved or certified in NALS, and what's next for the program?
So I'll start, and then certainly, Julie, Sarah, jump in. And I'm going to focus right now, kind of just from information perspectives, and whether it be coming through, links through AWHONN or Red Cross, redcross.org, /NALS, will get you kind of the information and get you started if you're interested in the program. And we can talk to folks, but it's really about that kind of certification piece. How do we make, and this is one of the other challenges. I knew Sarah was going to ask this question. So, other challenges, we built a new program, and Red Cross has history of this. We did this back when we launched our BLS, ALS, and PALS programs into the healthcare markets, 6-7 years ago. Now we have over 4 million certifications, but how are we going to do that with neonatal? And really what we're talking about is taking existing experienced instructors that are teaching, predominantly the NRP program, and allowing for a free bridging process for those instructors. So if you're an instructor, there is an online course you can take that's no cost that will prepare you to become a Red Cross instructor. And same for instructor mentors from NRP. Instructor mentor can take in a Red Cross instructor trainer program online. Now, you will take the online blended learning session. We want you to see the Red Cross curriculum and pass through it from a cognitive perspective, but then also kind of go through that process of learning how to teach the program through our bridging programs through the Red Cross. Again, so we put a system in place where it's very easy to bridge over. You just have to verify credentials. Ideally, you have a base level NRP certification or credentials, not certification. An NRP credential, we know some do not maintain a base level because of the instructor is considered that. But ideally, we're going to verify you exist. You have the appropriate credentials, and then put you into the online bridging process. Again, a couple hours, and we're not talking about a lot of work here. At the same time, once you are trained as an instructor, a Red Cross instructor, you need to become affiliated with a Red Cross licensed training provider. So a lot of hospitals, a lot of EMS agencies, a lot of other education centers out there already have Red Cross agreements, but there's actually a fairly simple process. We connect to kind of really with our team at the Red Cross to look through obviously the appropriate things with agreements and what the courses will cost and all those kinds of things. We'll go through that, but kind of really just a simple process of making those connections and becoming a licensed training provider for the Red Cross. Doesn't mean you can't teach other courses, but in order to teach NALS, you do have to be either a Red Cross employee, volunteer, or affiliated with one of the Red Cross training centers, an LT, which we call them an LTP, but it's really just a training center. Simple process. I think Julie and Sarah both been through parts of these processes already. So I don't know if you want to talk about what we've been doing, Julie, on the instructor development side.
We have actually, yes, you're right. I went through it and I think it was really important that I went through NALS, because it gave me this real flavor of the material itself, the simplicity, if I can use that word, the directness, the clarity of the information. And whether you're, again, a physician, an EMT, the basic messages came through. I really liked that. Is it adaptive learning? So if you come in with 20 years of experience or 30 years of experience, it's going to gear you. You've got the foundations, and then it's going to sort of steer you into the scenarios, which I found to be, I'm going to say challenging, not easy. I mean, certainly an instructor can pass it, but I think that goes back to Jonathan. We were talking about, are we diluting to the outside world? We are not. We are bringing the outside world that has been traditionally outside of Neonatal Advanced Life Support in. So I really like that critical thinking that we're using and guiding them through all of that. And I did want to just touch for a second on maternity care deserts, because we've talked about it a couple of times, and I think it very much affects the future of NALS and Neonatal Advanced Life Support across the board. When I first became aware of maternity care deserts, as put out, March of Dimes has done great information on this. I always thought of those as being in another country. I'll be very honest. And surely, if you're in the United States, surely there's a hospital around the corner that can care for all of your medical needs. And when you take a look at the map, and I challenge you to do that, when you take a look at the map and realize that over a third of the counties in the United States are maternal care deserts, which means that they have no OB services, that while they may have hospitals, the hospitals do not have OB services there. There is nothing that speaks to the pregnant parent. And that now brings challenges. And you think, oh, well, now that we've recognized this, we're fixing it. Actually, we're not. It's getting worse. The numbers are going up, and we probably, for those watching this, you're thinking, oh yeah, that's right, that hospital down the way just closed their OB services. There's a lot of financial and different things that play into it. So what does that mean? So what happens is we have parents that are not able to find maternity care, so we have higher amounts of no prenatal care, which means that we have more surprises when we have congenital defects, when we have multiples, when we have preemies. And quite frankly, if there's a hospital with a sign that says hospital, people are going to show up in that emergency room needing to be taken care of. So the EMS services, the community services, those hospitals, those birthing centers, outside of there, we need to be ready for this. So there's more and more need to get this information out. And again, bringing them up, giving them the tools and the science that we currently have in the hospitals. We want everybody to have that same science to take care of babies. How many are we talking about every year? We're talking about roughly 150,000 pregnant patients in the U.S. every year in these maternity care deserts. If we go by our stats, about 10% of those are going to be newborns requiring additional assistance in resuscitation. So we're talking about 15,000 babies needing resuscitation every year in places that we don't traditionally think of as being resuscitation centers.
Thank you so much, Julie. That is so true. So what advice would you give to those who want to bring NALS to their organization? What is the very next steps?
I mean, I think there's different steps to think about here. Certainly, from a program administration or education perspective, looking at the program, involving all the stakeholders. What we found is that a lot of large systems have looked at this from a nursing perspective and have made the decision to bring NALS in to their institutions, but they didn't include the neonatologist. They didn't include the emergency department. They didn't include the chief nursing officer or the chief medical officer in the conversation. So I think it's really, really important if you want to bring this into the institution and kind of bring NALS as an option internally, have the right conversations early. Certainly contacting through AWHONN, contacting through the Red Cross. We can get you all the information that you need, whether you need to, that the ebooks, the instructor manuals, just the kind of base information, and then the agreement processes. We can handle all that. That's actually really easy. It's actually the conversations internally of how do you evaluate a new program and look at it both from a science perspective as well as from a cost efficiencies perspective as well of what makes sense for the institution. So, but have that broad conversation. Don't isolate just to the NICU or just to labor and delivery. We need to kind of be holistic around the entire institution, really to be successful. We're seeing the hospitals that have brought everyone together to make these decisions have been more successful and had less barriers to jump over kind of post-decision by doing that. So I think that's some of the advice from an administrative perspective. And certainly, a lot of times I say this sometimes to my kids and my wife says, this is not jail. You can look at the program, you can try the program, you can kind of run some programs maybe as outreach and then bring it internally. Like we're not saying if you use NALS, you can't use other programs. We'd love you to incorporate NALS into the entire system, but really it's kind of look at what it can do and evaluate the program based on its merits of the same science, no bedside conflict. There are certainly, we haven't even talked really about the financial side of this, but it is a less expensive proposition overall to bring into the institution. And now's a great time. Right now, there's a brand new program. Other new programs are coming out. So this is really the time to evaluate before you invest another year or 2 years or 3 years of instructor materials and updating and all those things. You really want to do that once. So this is the best time, I think, to bring all that together is to look at the NALS today. So that's my advice from an institution perspective. I don't know from a nurse educator's perspective, Julie, Sarah, what your thoughts would be.
I think you're right on track, that holistic approach. And if I was going to include some others, and you just touched on it, for outreach, as you're doing your quality initiatives and your projects and your outreach, it's a wonderful tool for that. So make sure from the outreach coordinators, the quality folks, even risk managers, as we are giving feedback sometimes to our referring hospitals that come to us as a higher level. It's a wonderful tool and really written to enhance their science and bring them up so that we have this continuum of care.
Absolutely. Thank you so much. I think you guys hit it on the head.
Kudos to you all for creating such an amazing, innovative, and evidence-based program. It's really noteworthy that you're excited about how the educational delivery encompasses so many different types of healthcare providers and professionals across multiple settings, and that you've made such a deliberate effort to expand the reach to maternity care deserts. The uptick of NALS and how organizations are changing their protocols speaks volumes. One of the key points that I gathered from you both, Jonathan and Julie, is use your resources. This is a significant critical thinking skill for all participants. And I also really love the phrase no bedside conflict, because it's all about saving the lives of these newborns. So for our listeners, if you'd like more information about the NALS course, including how to register and bring it to your facility, you can visit this episode's resources at awhonn.org/podcast, or go to the American Red Cross website at redcross.org/NALS. That's ANALS. And on our AWHONN website, you can read Jonathan and Julie's full bios. If you want to share this with a friend, you think they could use this at their facility or with another healthcare professional, feel free to subscribe to AWHONN on YouTube. You can re-listen on Spotify and Apple Podcasts. We ask that you do share it widely, and also leave us a comment if you have any additional feedback for our team. And stay tuned to more episodes from A1 Insights. Thank you all for listening. Be well and stay safe.